Hi, and welcome back. This is Thinking Out Loud, presented to you here exclusively on the Saltwire Network. I'm Sheldon McLeod, and I'm lucky. I've had a family doctor. Now, the doctor we had when our children were born, not the same doctor. We moved communities, and back in the late 90s, early 2000s, it was still fairly easy to get a GP, a family physician. But that's not the case for a lot of you. I know, according to what the provincial government tells us, that there is roughly 1 in 10 Nova Scotians who are without primary health care, a family physician, and that puts a lot of pressure on the emergency system or walk-in clinics. And we saw this in the news just this week. Nova Scotia virtual healthcare program expanded to all residents without a family doctor, and this is virtual care. It used to be you'd have to get an email to be able to sign up. Now they're saying that's not the case. You can go in. They're calling it free, effective, and convenient for Nova Scotians to get medical care. Now, the government in Nova Scotia, now 1 year old, did not say they promised a doctor for every Nova Scotian, but they did promise to fix healthcare. And I just got to say, that's a monumental task. And I wanted to introduce Dr. Leisha Hawker to the conversation. She is recently become president of Doctors Nova Scotia, the association that represents the views and helps negotiate and discuss and the public face of the physicians in this province. So, Doctor, very nice to see you. Thank you so much for doing this.
No problem. Happy to be here.
I did note that there was a CBC story today, an investigative report talking about doctors who lost money during the pandemic and doctors who made money during the pandemic. I was just showing that news conference. One of the first things you did was you were invited to a news conference to talk about changing the payment model for doctors. Before we talk about the online part of it, can you tell me whether or not that those pilot projects in those 3 communities, do you know anything about how well it's working or not well, or how it's not working right now?
As you said, during the pandemic, some physicians' pay actually changed for the better or for worse. Many fee-for-service physicians might have suffered, especially surgeons, as they canceled a lot of ORs to try to keep the COVID rates down. And so there was a program in place for some of those physicians. If it set a certain threshold, then the government would kind of top up their pay a little bit. And then this blended capitation model that you spoke of, the evaluation is not done yet, so it's hard to say how that's going. It's also a payment model that will hopefully help primary care physicians. So patients have become more complex over time. We have an aging population, and it's not easy just to practice 15-minute visits for many of those patients. And this blended capitation model, instead of paying you per visit, it's a little bit focusing more on quality of care and not quantity. And so it can help the physician change their way of practice.
Now, I do consider myself lucky. I had to get in touch with my doctor. I got a telephone appointment the next day. I have to wonder, though, the virtual care, that's a little different. How do doctors populate that system? I saw a number as to how many physicians were doing that. How do they receive pay?
I believe that payment model is a sessional or an hourly rate. The physicians, the majority that are working in the virtual care NS, are either physicians that have retired or in the process of retiring, and they're kind of doing it as an add-on, or full-time physicians that are just taking an extra half shift or half day here and there as their schedule allows. So a lot of these physicians don't have the capacity to take on these patients full-time, and this is really just an interim solution. The long-term goal is to have enough family doctors and nurse practitioners so that every patient, every Nova Scotian has a medical home like you do.
But every Nova Scotian without a doctor right now, is struggling to try and find a way into primary health care. Worse if there's an acute issue. Obviously, Emerge and stories of people who are taking their X-ray requisition into Emerge because the backlog is 3 weeks. I mean, there's so much happening, and I have to ask, how is that weighing on the members of Doctors Nova Scotia? There was another story that my colleague Paul Schneiderite wrote talking about the amount of stress that has been put on our primary healthcare providers. Any thoughts on that?
There was a recent survey from the Canadian Medical Association that showed significant burnout rates and low professional fulfillment. And it's worsened since the time they did that survey previously in 2017. There's been significant stressors with the pandemic, But the thing that I think is harming physicians the most is what we call the moral injury or the moral distress. It's really hard when you know what your patient needs. So say you have a patient that has signs of possible colon cancer. It could be something else, but that's one of the things you want to rule out. The wait time, for instance, for scopes to rule that out is incredibly long. So it's frustrating for a family doctor, for instance, who's managing patients that they're waiting for their knee surgery or their hip replacement, whatever it is that they need, and you're trying to manage them, but the wait times are just much longer than they really should be.
I've seen an evolution. We've heard about it in the media, the way that old school, I'll use those air quotes, old school doctors, family physicians, they might have 1,000 patients. They may have many more than that, but the capacity now is for more of a work-life balance. I mean, we talked about the mental health stresses. So how do we look at a promise to fix healthcare? Never mind a promise for a doctor for everyone, but a promise to fix healthcare. Do you feel that we're on the right path? Is there a clear, well-defined plan to do that?
You're right. A lot of the kind of younger physicians are looking for a bit more work-life balance. There's more and more women and gender diverse folks going into medicine, and there's more folks who are physicians who have a full-time family role too. So as more women are family doctors, we have like the second shift, as some people call it, when you come home and you're doing all your family stuff as well. And so it's different. Back in the day, a lot of our family doctors when we were growing up were older men who had a wife that maybe stayed at home, and it's different now. So physicians have a little bit more on their plate than they did before, and so they want a little bit more reasonable hours. The younger physicians also are looking for a bit more flexibility. So we're seeing a lot of younger family doctors, for instance, that aren't interested in having a full-time family practice and maybe having a practice share or working part-time and then doing something else part-time. For instance, I work in addiction medicine and at the refugee clinic in addition to my primary care clinic.
And I guess to that question, though, do you see a plan that's being spelled out that clearly identifies where the problems are and how to fix them?
I think when we focus on recruitment and retention, we need to have the flexibility in our payment models and in our employment contracts so that physicians see themselves when they see a job opportunity that they think it will work for them and for their families. Sometimes we'd see like a really restrictive full-time equivalent family practice job, and then we might not get as many people interested because it's not what people are looking for these days.
Here we have, this promise to make the system work more efficiently. We talk about recruitment and retention. The Nova Scotia government recently has announced it will be working to help get qualifications for those who may be practicing medicine or working in nursing in other parts of the planet. Specifically, we're talking about recruiting from Ukraine, where obviously there's a lot happening right now. And I know you're not with the Nova Scotia College of Physicians and Surgeons, but does Doctors Nova Scotia have a position on being on bringing in or certifying doctors who may have had their education outside of Nova Scotia or North America?
As you mentioned, it's the college that ultimately decides who will have a license to practice. But we do work together closely with the health authority, with the Department of Health and Wellness and the college, and we advocate for easing the burdens for international medical graduates. We also have a mentorship program for international medical graduates that's led by a physician here in Nova Scotia that is an international medical graduate himself. And that pilot for that mentoring program is really just getting started, but we're hopeful that it will help international medical graduates once they're here and practicing in Nova Scotia to really succeed and to stay for their full career.
Now, you have a perspective. You obviously have more knowledge than most people, but I'm sure you've heard folks say, well, if you're a doctor in Europe, why can't you just immediately come to Nova Scotia and work in a hospital?
For the past about 2 months, I've had an international medical graduate from the UK working with me, and she's been doing an observership, and she's highly knowledgeable, has been here for several years, understands the healthcare system well, and I look forward to writing lots of letters of recommendation soon, so hopefully she'll get a residency training spot so that she can finish her training and hopefully stay in Nova Scotia.
So that's one example. So it does happen, but what is the fear? Just again, I know that you're not with the physician, or with obviously the College of Physicians and Surgeons, but can you help us understand what the reluctance is, or the hesitation, or why these processes were needed and are needed?
Well, the colleges have very high levels of standards of what they expect for a physician to be licensed in Nova Scotia. We're also advocating for what we call a national license, or even hopefully maybe an Atlantic or regional license, because that will also help Canadian medical graduates, but also international medical graduates, to test the waters, so to say, in different provinces, and then hopefully they'll come to Nova Scotia and fall in love with the place and stay here.
And you touched on the next question, which is, we're trying to bring more doctors into Nova Scotia, but you, Dr. Hawker, can't go to New Brunswick and practice, or you could, but there's a process and it takes time. So what are we talking? How are we talking about, relaxing? Maybe that's not the right terminology, but addressing that barrier to even cross-border migration of physicians.
Yeah, a lot of people don't realize that physicians don't have the similar mobility to other professions, that it's quite burdensome actually, and it's a long paperwork process to get a license in another province, and there's usually a huge fee or cost along with it. So a national license would go a long way in standardizing the requirements across Canada, but also allowing more physician mobility, which would help with recruitment and retention. It would also help with filling in gaps. Say there's like an urgent need somewhere. When I first finished residency, I worked here in Nova Scotia as well as the Northwest Territories, and I would go there for about a month at a time, about 3 or 4 times a year. And then when I had my license there, every once in a while, their locum for the entire health authority, they'd have one doctor on call, or in that area. And sometimes it would fall through for whatever reason. And I actually provided remote on call from Halifax to the nursing stations there. Now I don't have a license there. So if they were in an urgent need, I wouldn't be able to, by the time I got a license, that need would have already passed. So if we had a national license, we could all kind of help each other out on a more urgent basis.
It seems like in some ways we're leveraging technology to help provide primary care, but we're neglecting the licensing aspect to allow it to happen across borders.
Yeah, and virtual care, we're still not using it as much as we could be. So when I was working in the Northwest Territories, they had something called Consult Derm, I think it was called, and I could actually send a photo and a description of, say, a rash or a mole or something to a dermatologist in Edmonton, Alberta. And a lot of the cases could be handled remotely, and within a few days I would get a message back saying, I think it's this, that needs this treatment, or it needs excision, or sometimes they need to come to Alberta, I need to see it. And so those kinds of things we still don't have in Nova Scotia very much. There's some pilot projects for e-consults with the health authority through something called Virtual Hallway. But I think we need to really maximize our use of synchronous and also asynchronous virtual care.
Our premier said in fact, he went on a tour just after becoming premier to say, I want to hear from the doctors and the nurses and the interns and the personal care workers. I want to hear what might be ways of helping this situation that's not great. So do you feel like you've been listened to, that you're being heard?
Yeah, when they first came into power, I think they did a great job with their Speak Up for Healthcare campaign. I was able to participate in one of their events, and overwhelmingly physicians and other healthcare providers, I think, felt really heard and seen and optimistic, because we are on the front lines. We see the issues, firsthand, and a lot of us have solutions or things that we think could really help the system. And so the more that you engage with those that are kind of working boots on the ground, I think the better the solutions and more quickly we can fix the system.
So more virtual care, national licensing, or even Atlantic Canadian licensing. I'm hearing a few suggestions here. Where would you like to see this province go with its healthcare fix in the next 12 months?
One other thing I'd like to really see working on is expanding primary care collaborative health centers. One of my main practices is the North End Community Health Center on Gottingen Street, and I'm really fortunate because I get to work with wonderful nurses, nurse practitioners, mental health workers, housing first workers, harm reduction, peer support, dietitian. We have dental, you name it. We pretty much have everyone. I'm missing physio. I really wish I had physio too. But the patient doesn't always see me. They see our social worker, they see our mental health worker, they see our nurse for diabetic education. And it expands our ability to have more patients at the community health center. But it also means that the patient is getting almost all the care they need right in that health center. They're not having to leave the clinic very often. We do our own blood work. We have our own prenatal clinic. We do our own addiction medicine work, so they're not going outside that. We even have visiting clinics from obs-gyne and internal medicine, and we're hoping to expand that as well into other specialties. And so I think if we took that model and expanded it across Nova Scotia, we'd be able to have more patients at each community health center. And it also is a bit of a one-stop shop. So they're getting really comprehensive care and also good continuity of care.
The president of Doctors Nova Scotia, Dr. Leisha Hawker. Thank you so much for your time today. I appreciate it.
No problem. Happy to come back anytime.